Muy buenos días, bienvenidos todos a este primer webinar del Encuentro Latinoamericano de Cápsula y Endoscopía. Soy la doctora Clara Martínez, presidenta del encuentro, y me permito dar la bienvenida a este primer webinar a nuestro profesor Cristiano Spada. Realmente para nosotros es un placer iniciar este tipo de webinars con su presencia. El doctor Cristiano Spada es profesor de gastroenterología y director de la unidad de endoscopía digestiva quirúrgica del Departamento de Ciencias, Medicina y Endocrinología Metabólica de la Fundación Policlínica Gemelli en Roma. Doctor, es para nosotros un placer verdaderamente recibirlo a este webinar y me permito presentar al panel que nos va a acompañar durante su conferencia. Estará con nosotros la doctora María Teresa Galiano, cirujano gastroenterólogo, que es actualmente la secretaria del encuentro de la ciudad de Bogotá, Colombia. Estará también la doctora Carla Díaz, gastroenteróloga endoscopista de la ciudad de Caracas, Venezuela. Y el doctor Hugo Cedrón, gastroenterólogo endoscopista de la ciudad de Lima, Perú, que es actualmente el director de difusión del Encuentro Latinoamericano. Nos acompaña también el doctor Fernando Contreras, gastroenterólogo endoscopista de amplia experiencia en cápsula endoscópica de República Dominicana. Y nos acompaña el doctor Carlos Golbán, gastroenterólogo endoscopista de la ciudad de Buenos Aires, Argentina. Bienvenidos a todos y doctor Spada, muchas gracias y adelante con su presentación.
Thank you. Thank you very much. I will go in English because it's easier for me, even if I speak a little of Spanish. But then, if you want to, you can make your question in Espanol. Well, I'll try to present my experience in capsule endoscopy, and in particular using the system by Anix, the Navicam system. So what's the background and why we are very much interested in the Navicam, and in particular when using Navicam, the artificial intelligence? Well, probably you know better than me that when we talk about capsule endoscopy, we use, and also in papers, we used to define the capsule endoscopy as a non-invasive, patient-friendly endoscopic tool that is able to explore the small bowel. And it's true because it's endoscopy and is absolutely non-invasive, and so patients really have a very nice experience, and the patient experience is always very positive when we use capsule endoscopy. But we always forget about the doctors and about the physicians, and mainly the physicians who have to look and to spend time to review and read the capsule endoscopy. We know that we spend a lot of time in front of our workstations, and basically we spend our time looking at a very long series of normal images. And so we have some problems with this because there is a risk. And the risk is that we can get distracted and we can miss easily a few findings, even relevant findings, that are visible only in few frames. And this is a big problem, and because the capsule endoscopy, the video capsule endoscopy, actually is a huge amount of images that are collected all together. Our videos usually range between 50 and 60,000 images. And if we look at the reading time, well, basically this is true, it's time consuming. Even in experienced readers, we have at least a reading time or to read and report the video capsule recording that can last between 30, but it could be also longer. As a result, our job, unfortunately, is very time-consuming. There is the risk of oversight. We should consider also the risk of the fatigue of the endoscopy. And as I was mentioning before, we can get distracted. We are looking at the videos, we get the call, and let's just few seconds, and we lose even relevant images. And the problem of cost. We stay in front for a long time, we invest our time, and most of our time actually is spent not for relevant findings, but for normal findings. The other problem that we have is that you know that now we have an obsession that is quality, and this is a good obsession. We are very much focusing on quality in endoscopy. And the ESGE, the European Society of Gastrointestinal Endoscopy, actually invested a lot to improve the quality. And the quality for capsule endoscopy is mainly related to the quality of reading. Because if we go back to the problem of the risk of missing finding, in the vast majority of the cases, these findings that are missed are present, are available in the video, in our video, and the problem is the reader that was not able to detect the finding. And in fact, this is a nice paper, and that was published a couple of years ago, and they went to analyze what is the inter-observer and the intra-observer agreement. And if you look, we are not good at all. Actually, we have in the inter-observer agreement, that means between me and you, when we look at the video capsule endoscopy, actually we agree on the result only in one case every 4. And there is no agreement at all in 21% of the case. But also, if we look the intra-observer agreement, that means that is myself looking one time the capsule, and then after a few months or few weeks, I redo the reading. Actually, my intra-observer agreement is still very, very low, because it is about 35-36%. So the problem of reading is a crucial problem, and it's a very sensitive problem. And this is not a new problem. And also companies during the years try to solve the problem of reliability of the reading, so the inter and intra-observer agreement. And the second point is to reduce the reading time. Actually, is experience of everybody using the quick view, the suspected blood indicator, the top 100 selection. But if you see, the guidelines never adopted and never recommend these kind of basic artificial intelligence algorithm, because they are not good enough. They are good to preview our video capsule endoscopy, but they are not good enough to replace the standard reading. So the big change, the real big change, went at when the convolutional neural networks entered the endoscopy in general, and in particular today is capsule endoscopy. So what's the role of capsule endoscopy, of artificial intelligence in capsule endoscopy? It's not very much different from the role of artificial intelligence in general in endoscopy. And we are mainly dealing with detection, lesion characterization, but then we have also some specific issue that are, or fields that are specific for capsule endoscopy. That is the prep evaluation. Today, we still do not have a real validated scale. After 20 years, 25 years that we are using capsule endoscopy, unfortunately, we are still missing a real validated scale for prep evaluation. And also the capsule localization. This is another big problem. Today we are using time. We are still using time and to define where is a lesion. But we know that the transit time of the capsule through the small bowel is not uniform. So dividing the small bowel in 3 portions, in 3 tertiles, only because of time, this is very imprecise. And then again, we go back to the problem of quality parameters, quality parameters evaluations. And we really need a system that at the end of the examination suggests me, or after a certain numbers of examination, they tell us something about our quality, something about discretion, the completion rate, the quality of prep, the detection rate, the characterization of the lesion. And one of the first companies that actually produced and developed a system, an artificial intelligence system for a capsule endoscopy actually was the Ancon. And the goal was to have a system, a software with a high sensitivity and a high efficiency. When we deal with sensitivity, so it means that the system should be accurate in detecting findings. And when we deal with efficiency, an efficient system, it means that can reduce very much our reading time. And they did a huge, really huge job to train the system. Look, they used 113 million images from almost 7,000 videos, first to train the system and then to validate the system. So that was a real good, a tremendous big job. But you know that the training when we deal with artificial intelligence is crucial, because the system we call artificial intelligence, but actually it's not intelligent. The system can recognize what was trained to recognize. So this is crucial, because I will show you later, if we don't perform a proper training, then the system can make big mistakes. And this is an example of what we mean with artificial intelligence. What could be the benefit of using an artificial intelligence? So this video is basically how we are used to look at the capsule endoscopy. So we sit in front of a workstation, basically looking at normal images. And we spend a lot of time looking at normal images. The artificial intelligence is exactly when we activate this ProScan, the system is able to recognize what is abnormal and completely delete, don't consider what is normal. So the system is able to bring your attention directly to what is abnormal. And we are not dealing now, up to date, we are not dealing with characterization. We are simply dealing normal versus abnormal. And we had some preliminary data about this one. And this is the first paper that was published in Gastroenterology in 2019. And that was a real surprise for me, because you see that the sensitivity in the per patient analysis and per lesion analysis, when we used the artificial intelligence, was significantly higher than with conventional reading. You see, in the per patient analysis, the sensitivity was 74% in conventional reading and 99% in the artificial intelligence-based reading. That was a surprise for me. How we can explain this huge difference? Well, for me, the main explanation for this is again the problem of reading and the fact that we miss images because we can be distracted or we are not focusing too much on the relevant images. And the artificial intelligence is never distracted. The artificial intelligence is always working at the best, 100%. And look at the reading time. In this paper, the conventional reading was 96 minutes and went down to 6 minutes when using the artificial intelligence reading. So what was missing at that time? That was a retrospective trial, and so we missed a prospective trial that was a single center. So we aimed for a multi-center trial, and that was not blinded. So we designed a trial, and the trial is the Arctic trial that was published 3 days ago, finally in Lancet Digital Health. And we designed this multi-center European blinded prospective trial. And we included only patient with bleeding, with suspected small bowel bleeding. It's a consecutive series of patient with suspected small bowel bleeding. And at that time, we didn't know very much about the artificial intelligence, and so we designed a non-inferiority trial. So our assumption, our hypothesis was that at least the artificial intelligence was performing at least as a group of experts. And we did an analysis in a per patient analysis, but also in a per lesion analysis. And we consider only the, according to the Saurin classification, the P1 and the P2 lesions, so the lesion that are responsible for the bleeding or lesions that are suspected to be the reason of the bleeding. Then we went to analyze the accuracy and the reading time. And this is the flow, just very easily, no? The patient were enrolled to perform the capsule endoscopy for suspected small bowel bleeding, and this enrolling center performed the standard reading. Then we blinded the video, and we sent the video to another reader that was completely blinded about the result and the medical history of this patient. And this second reading was performed using the ProScan, the artificial intelligence. Then we unblinded the two reports. The report that was performed using the standard reading and the other report using the artificial intelligence. And then if there was a discordant result, we invited a board of experts to rule out the two videos, to redo the reading of the two videos, and to say what was wrong and what was right. And we included 150 patients, and we really had results that went over our expectations. You see that when we look at the diagnostic yield, and the diagnostic yield was significantly higher when the reading was performed using the artificial intelligence, when using the group of P1 and P2 lesion However, when we deal with the most important lesion, they are the P2 lesions, there was an improvement of the reading when was performed with artificial intelligence, but it didn't reach the difference, the statistical difference. So we were not able to confirm that when reading the capsule endoscopy with artificial intelligence is not inferior than standard reading for P1 and P2 lesion, and was even superior when we consider the overall group of P1 and P2 lesion. And if we look the accuracy parameters, you see that we have a statistically higher sensitivity, negative predictive value, and the overall diagnostic accuracy was significantly higher with artificial intelligence. As a different surrogate of the quality of prep, we went to analyze the missing rate in the per patient and per lesion analysis. And again, when we read the capsule with the ProScan, having the expert, the board of expert as a gold standard, you see that the missing rate in the group of artificial intelligence reading was significantly lower. And when we deal, we already had, you see, for and we went to analyze the reason of misinterpretation. Actually, the problem was not the software. The problem was always the readers that was missing lesions. And when we deal with the diagnostic yield, this is interesting because you see that when there is a statistical difference between the standard reading and the board of experts. And between the standard reading and the ProScan, there was an improvement in the diagnostic yield of 18%, almost 20%. However, there is no difference between the ProScan reading and the reading performed by the board of experts. So this is, at the beginning, was considered as a suboptimal result, but basically then we consider this as an excellent result, because it means that the ProScan alone can perform as a group of 1, 2, 3, 4, 5, 6, and myself that was shooting the picture. So the ProScan alone is as the same result as the result that are obtained when 6, 7 experts are sitting together in front of a capsule reading. And then when we look at the per lesion analysis, again, here we have the same result. The diagnostic yield is significantly higher when we deal with when we look at the video using the ProScan, the artificial intelligence, and again the per lesion analysis, we were able to confirm that there was a non-inferiority, but there was also a superiority of P1, P2 lesion, and also for P2 lesions only in this case, there was a non-inferiority. And again, if we look at the miss rate was significantly lower when the reading is performed using capsule, using the artificial intelligence. And finally, I would like to make a comment about the reading time. Look that the small bowel reading time in standard reading in our study was about 33 minutes, and with artificial intelligence was less than 4 minutes. And also, if we consider the entire video goes from 43 minutes down to 6 minutes. So we can reduce by 10 times the reading times, and we can reduce by 20 times the number of images that we look in a capsule when using artificial intelligence. And this is an example. In these two videos on the left, the video looking at the standard reading, and on the right with artificial intelligence. We start immediately the same time, 18 minutes here and almost 80 minutes, and we leave running these two videos for 30 seconds. I invite you to look at this blue bar, and you see how it's jumping from one side to another side. And the reason is that is simply jumping to relevant lesion and is disregarding completely the normal images. And so if we look at the on the left side, you see that here the bar goes extremely low. So if we start at the same point the video, and we look at this point in these 30 minutes, is like we are reviewing all 2 hours, almost 2 hours of video. And this is brilliant. I think it's brilliant. And so I think that we should admit that at least from these two preliminary study, we can improve the efficacy and in terms of detection, and we can improve the efficiency, reducing very much the reading time. We are really at the very beginning of the history of artificial intelligence in endoscopy in general, and also in capsule endoscopy. Now we are dealing mainly with reading time and with detection, but we will have for sure characterization. We will have a system that is able to make measurement of size, to evaluate the clinical relevance of the lesion, to have an homogeneous nomenclature in order to improve the inter-observer agreement, to evaluate the prep quality, and what I think it's most important, to improve the final outcomes in our patient. And in fact, if you look, this document that was from ESG, European Society of Gastrointestinal Endoscopy, and is about the expected value of artificial intelligence. Well, the three main topics that artificial intelligence should try to improve in capsule endoscopy is the scoring of cleansing level. The second, to evaluate the completeness of the procedure, so the identification of the cecum and the colon during capsule endoscopy, and the detection, so the identification of pathology. I was telling you that we are mainly dealing with detection, but we already have some papers showing that also we can adopt new softwares and implementation of this software in terms of characterization. And this is a paper, a preliminary paper, and look the accuracy and the sensitivity for the most common findings. They are absolutely excellent. But then I would like to invite you to look at this bar here, and it's about overall accuracy and the impact of artificial intelligence in trainees. When we offer a capsule without artificial intelligence to trainees, the overall accuracy is 86%, in expert is 97%. Then if we invite the trainees to use artificial intelligence, you see that they go up to 98%. That is exactly the level of the expert. So it means that probably if we use artificial intelligence, we can reduce very much the learning curve of our trainees. This opens a new door. Be careful, because this could mean also de-skilling, because it means that we don't know then if we remove artificial intelligence in the group of trainees, what happens to them, if they still keep the expertise that they reach with artificial intelligence, or they go back to the previous level. So when we deal with artificial intelligence in general, the skilling problem is an open issue. And the other open issue is the bias, and the bias that we can incorporate in when we train the system. I would like to give you an example. Disease, I think that everybody agree that the disease is a vascular malformation and angiodysplasia. So if I train the system to recognize this lesion or similar lesion as angiodysplasia, it will be able to detect very easily this lesion. But what happens if we train the system to recognize this one, that is a red spot, not significant at all, absolutely not relevant findings. And if I train to recognize this one as an angiodysplasia, we will have a lot of false positive results. So the training is a big problem, and we should be sure that the system that we are using are trained properly. So in conclusion, I think that we should admit that the preliminary data support and suggest that the capsular endoscopy is a prime candidate for early adoption of artificial intelligence. The ProScan is a very good system that is able to differentiate abnormal images from normal images, can improve the detection rate, and can improve the overall performance, reducing very much the reading time. At the moment, we have only one retrospective and one prospective study, and we really need other studies that will be able to confirm the real gain of artificial intelligence in capsule endoscopy reading. The other problem that we have is that the studies that have been performed are mainly performed in patients with suspected small bowel bleeding, and we should try to see and to evaluate if this system is good enough also for other indication, for example, in the group of Crohn's disease patients. And then what we also need very much is a cost-effectiveness study, and in order to see if when reading with capsule endoscopy, this approach is cost-effective. It seems to be yes, but we need trial. And also, we should understand what's the final impact of artificial intelligence in the clinical outcome of our patients. So I thank you very much. It was a pleasure for me to be today with you, and I would like to invite you, if for you is possible, to come to Rome next May for our EndoLive meeting. It's an endoscopy meeting. Thank you very much for your attention.
Mil gracias, doctor Spada. Excelente conferencia. Realmente nos muestra su trabajo prospectivo con sus resultados, que es el primero que se hace, y nos muestra elementos muy importantes para que tengamos en cuenta en nuestro futuro, en el avenir de la cápsula endoscópica. Voy a invitar a todos los panelistas que están presentes, la doctora Carla, el doctor Cedrón y el doctor Fernando, a realizar sus preguntas al doctor Spada, por favor. Si quiere, comencemos por la doctora Carla. Gracias.
Agradecida a la doctora María Teresa Galiano, doctor Spada, una excelente puesta al día de videocápsula inteligencia artificial. Es una verdad absoluta que la inteligencia artificial llegó a quedarse y avanzar cada día más en este mundo tan prometedor. En su opinión, ¿cuál cree usted que puedan ser las aplicaciones más prometedoras de la videocápsula de inteligencia artificial, Navicam en este caso, en el cual usted tiene una amplia experiencia en un futuro cercano?
Yes. Well, you know that when you will start using, there is a big discussion exactly about this point. Okay, what's next? And how we use this artificial intelligence software? Can we use as preview, so just to help us, or as a first reading or second reading? So before we do the reading, or after we do the reading, to confirm that our findings are there and that we don't miss. This is a nice discussion, and we are going to also to try to answer this question in another trial. But I can tell you one point. As a physician and as an investigator, we are always happy with new technology, but we are cautious and skeptical about new technology. It's true that we incorporate new technology, but we won't prove that the new technology are good enough. And so when I receive this system, I was a little bit more cautious, to say, well, I will try. It's not possible that it can do better than I do. And then you realize that it's true. It can do better. And I trust very much this system. I cannot say that all the systems are the same, because I do not have experience with other systems. We are using and we are starting experiences and studies also with other systems. But I can tell you that this system is good enough to be used in routine, because it's very precise, it's very sensitive, and then the reading time is extremely low.
Muchísimas gracias.
Gracias. Por favor, doctor Contreras, si
Sí.
podemos.
Sí, en primer lugar, felicitar al doctor Spada primero por el excelente trabajo, el excelente diseño, el aporte que nos da al uso de esta tecnología. Mire, yo tengo más de un año utilizando inteligencia artificial en colonoscopía, y la verdad que me emociona muchísimo ver esta data en la inteligencia artificial en la cápsula, porque obviamente, como bien decía el consenso europeo, la idea es que la inteligencia artificial sea tan buena como los expertos. Y aquí veo que la inteligencia artificial en detección es tan buena como los expertos, porque la verdad que no fue muy justo de que la compararon con un panel de expertos, ni siquiera un solo experto, sino un panel. O sea que yo creo que en cuanto a detección está tratando, o yo creo que está llegando a la cometida que uno quisiera, que es que los usuarios regulares sean tan buenos como los expertos. Ahora, tengo dos preguntas que son las mismas preguntas que nos hacemos con la inteligencia artificial del colon. La primera es, ¿cuál es el significado, si tiene sobre todo, del incremento de la detección de lesiones, sobre todo que parece ser como en la colonoscopía, que en las lesiones, por ejemplo, en la colonoscopía, en las lesiones de más de 1 centímetro no hay mucha diferencia, sino en las más pequeñas. Aquí vemos que en la P1 tiene más diferencia que en la P2, o sea que ese sería el primer efecto, si realmente esto tiene una ventaja clínica o una desventaja. Y la segunda es el tiempo. Cuando analizan por qué a los gastroenterólogos usuales no les gusta la inteligencia artificial de colonoscopía, es por la percepción de que le va a quitar tiempo. Obviamente la data aquí es impresionante en cuanto al ahorro del tiempo, pero eso solamente sería útil si nos atreviéramos a recomendar que podemos utilizar la tecnología solamente utilizando la inteligencia artificial. O sea, que tengamos la confianza de que con esos 6 minutos de evaluación de la cápsula podemos dar con certeza el diagnóstico, y no que usemos los 6 minutos, pero además de eso tengamos que leer la cápsula entera en la forma regular, porque entonces ya no estaríamos ahorrando tiempo, sino perdiendo tiempo. O sea, que quisiera oír los comentarios del doctor Spada con esas disquisiciones.
So the first question is true. Well, if you remember, we were able to prove the non-inferiority for the P1 lesion and the superiority only when we combine P1 and P2 lesions. But this is not bad. I mean, it means that the system actually is good enough and is at least as good as you, but you need half an hour, and the system can do the same job that you do in 3 minutes, in 4 minutes. That's so. I agree with you. Well, but it's a little bit different than for colon, no? Because actually we wanted to include also. We could include also the P1 lesions, and anyway, we were able to prove that it's not inferior. So it's at least like you are. But the time but it's not true, because when you use the artificial intelligence, it's even better than you are, because there is a gap, still a gap between you and the system when the reading is performed with the artificial intelligence. So this is the first question. The other question is about the time. And so the data coming from trials support the use of this system alone. But you should not trust me, and you should not trust the papers. I really invite you to use artificial intelligence, and at the beginning to do a double reading with and without. After, I would say, 4 or 5 cases, you immediately will stop to look with the standard reading, and you will go immediately with the artificial intelligence, because you will have experience that actually is good enough and is sensitive to detect all the spectrum of the lesion.
Gracias.
Mil gracias, doctor Spada, doctor Contreras. Doctor Cedrón, ¿tiene para el doctor Spada?
Doctor Spada, primero felicitarlo por la brillante charla. Fue todo un placer escucharlo como siempre. Y quería consultarle, bueno, desde que iniciaron los sistemas de cápsula endoscópica, ha habido diferentes formas de aplicar la inteligencia artificial, como mencionó, ¿no? Porque el detector de rojos, en cierta forma el Quick View o el Express View son formas de detección por inteligencia artificial, ¿no? Seleccionando imágenes e intentando ayudar en la detección. Aquí en Perú, lastimosamente, no tenemos aún sistemas de Navicam disponible, pero yo sí he tenido la oportunidad de usar diferentes sistemas, y creo que el más parecido es el de la cápsula de OMOM, ¿no? En OMOM, por ejemplo, lo que nosotros hacemos es descargamos primero la data, y luego aplicamos el sistema de inteligencia artificial. O sea, podemos no ponerlo, y eso nos toma entre descargar la data unos 20 minutos y hacer la inteligencia artificial unos 40. O sea, en total debe ser 45 o 1 hora más o menos para tener ya el programa realizado, y luego podemos verlo en la forma original o ver solamente las imágenes que selecciona la inteligencia artificial, ya sea en fotos o en videos. Entonces, me gustaría me culturice un poquito de cómo es en Navicam, cómo se ven las imágenes, cuál es el tiempo de descarga, ¿no? Porque ahora también cuando uso Pilcam, mi gran problema es el tiempo de descarga. O sea, el tiempo de descarga de un estudio es extremadamente largo, ¿no? ¿Cómo es con Navicam?
So the downloading time is quite rapid, and let's say it's usually it's more or less like the one that you experience with OMOM. It's, I would say, 40-45 minutes, and the quality of images actually is absolutely comparable to the other images, and really, frankly speaking, I can tell you that when we started, we were used mainly to Pilcam, and there was a gap between the quality of images between Anix, Ancon, the Navicam, and the Pilcam, but now this gap was really, the quality of images is very good. It's very good.
Gracias, doctor Spada, doctor Cedrón. Me gustaría preguntarle al panel de expertos Si tienen alguna otra pregunta para el profesor Spada, ¿alguno quiere preguntar algo más? Si no tenemos más preguntas en el panel de expertos, quiero agradecer nuevamente al doctor Spada en nombre del Encuentro Latinoamericano de Cápsula y Enteroscopia. Queremos invitarlo a estar presente nuevamente, felicitarlo por los aportes que está haciendo al mundo del intestino delgado y realmente nos ha abierto los ojos y todas las ganas de seguir con este tema de inteligencia artificial en Latinoamérica, que esperamos continuar en investigación y seguirlo a usted en sus resultados. Felicitaciones por ese trabajo tan importante que terminó publicándolo hace 2 días en Lancet. Creo que va a ser muy importante para el desarrollo de la inteligencia artificial. Mil gracias por su tiempo.
Muchas
su
gracias.
generosidad.
Thank you.
Muchísimas gracias.
Muchas gracias.
Gracias.
Hasta luego. Chao.
Gracias.
Bye.
Gracias.
Excelente, ¿eh?
Thank you.
Muy bien,
Gracias por la
muy
invitación.
amable.
Gracias.
Gracias por todo.
Gracias, doctor.
Gracias.